I'm Dolores Pretorius, and I'm from the University of California, San Diego, where I'm a professor, and I'm going to talk today about three-dimensional ultrasound in obstetrics, where you use it clinically. I want to just give you a couple learning points of what you should learn today. When you finish this talk, you should have an idea of what applications we use 3D ultrasound for in evaluating the fetal brain. You should know where cleft lips occur and where to look for them on the pictures, and how to render the cranium to see sutures. Now, of course, you're going to learn a lot of other things, but I want you to try to focus on these three things and make sure at the end of the talk you can do that. So here's a 3D picture of a little fetus, and you can see that the appearance of the baby after delivery is really very similar if you look at the nose, if you look at the area of the lips, if you look at the area of the philtrum right between the nose and the lips. It really looks very similar. So where do we use 3D ultrasound for in evaluating congenital anomalies? Well, probably the most common referral that I get for 3D ultrasound is for facial anomalies such as cleft lip and palate. Yes, we do get them for other facial anomalies such as profile, like micrognathia. If you can't find the nasal bone, sometimes 3D can be really helpful to decide whether you do have a nasal bone there or not. We also use it for ear anomalies, so families that have prior children born with congenital syndromes that have ear anomalies, 3D is really much more helpful, I believe, than 2D ultrasound. In the brain, we're using it more and more as a troubleshooting and trying to measure different structures and figure out whether they're normal or not, and I will show you several of those types of applications. People are talking about 3D ultrasound for cardiac anomalies, but in my hands, we use it predominantly for teaching how to get those outflow tracts, how to understand the three-dimensionality of the heart. And we are just beginning to use it to look for actual anomalies themselves. We do use it for spinal anomalies, particularly identifying the level of a spinal abnormality or a fetus that's in a terrible position to look at the spine. We use it for some extremity anomalies such as club feet or cut off fingers or abnormal orientation of the hands or feet. And then lastly, we use it for some vascular anomalies like vasoprevia. How far is the villamenous cord insertion from the cervix? I can't quite get it in the right plane. I can take a volume and identify how far away it is. So I want to start with facial clefts because it's our most common referral. And this is a diagram from an article from 2006 where you can see the normal alveolar ridge here, and this is the hard palate here, and then the soft palate is back here. In a unilateral, we tend to get our cleft right here, often going up into the nostril, just into the lip. Whereas here we have a cleft lip and palate going all the way through the alveolar ridge. There we have a bilateral cleft lip and palate. And this picture does remind you that sometimes it's hard to decide whether you're looking at a cleft or whether you're looking at the nostrils themselves. Here is a unilateral cleft lip and hard palate going all the way back. And here's a bilateral cleft going all the way back. And there are lots of variations. You can have a hard palate coming on the right, and you can have just a lip on the left. So it is something that you have to definitely look at on both sides. We can also have isolated clefts of the hard palate or of the soft palate, and these are much more problematic in being able to identify. But there are case reports now identifying some of these. Now, this is a paper that came out of our lab at UCSD, and we learned a lot from just making this picture because we learned that the primary palate is really just the first 4 tooth buds, and the rest of the alveolar ridge back here is really the secondary palate. where we see from here back, and it's from this little point called the incisive foramen back as the secondary palate. Here you can see the clefts generally occur through that lateral incisor, the second tooth bud over is where we get the clefts. So if you can see the front 4 tooth buds, you probably do not have a cleft lip, or a cleft palate. And so that's a very important thing in deciding when you're going to clear your palate. Now, I really like this diagram from Dr. Stuart Campbell from an editorial he wrote in the White Journal, because it reminds us that the hard palate is up here between the 2 blue areas, and the soft palate is posterior here, and it's curved. So you are not going to see the soft palate clefts or hard ones on the same plane unless you do a curving rendering of that palate. Now, Dr. Millard is a plastic surgeon who's sort of the guru of clefts, and he has a huge 3-volume book on plastic surgery of clefts. And I just took a few pictures from his book showing this isolated unilateral cleft lip coming back into this hard palate. And you can see part of the normal palate here as well. And these are masks of clefts. Here we have a bilateral that looks a little bit like ET with a premaxillary mass right here that has 2 tooth buds in it. Sometimes they do, sometimes they don't. But this one does, and sometimes these are kind of hard to see the cleft, but the premaxillary mass is pretty obvious. And then here's an isolated cleft palate back here. And then I wanted to show this picture that shows variations of the hard and soft palate to remind you that they don't all look exactly like you would imagine from our diagrams, but some of them are really quite unique in how these clefts are formed. They're certainly midline here, but they're not just like you might draw out and expect. So here's a patient that has a cleft lip and palate, and this is the frontal view on 2D, and there's this area here that's worrisome. And then on the axial view through the palate, you can see that there's a gap here going into the alveolar ridge. Now, you don't know exactly whether it's midline or whether it's right or left, but this one is labeled left, and certainly turned out to be that way. Here is a multi-slice picture through the face, and I want you to just notice the orbits, and then we're coming down every 2 millimeters into finally we get into the palate, and you can see the anterior alveolar ridge right there, and a little bit better where you can see those tooth buds. Those are the front 2 tooth buds, and then here's our lateral ones. And then we keep going down, you see the tongue, and then further down, and we see the mandible. Now, the mandible can often look very similar to the palate. And depending upon how you angle it, the palate will be more horseshoe-like. And the mandible tends to be just a little bit wider. Here we have a videotape of a cleft lip and palate. And first we are magnifying the volume in order to get the profile in the upper left-hand corner just by panning. And then we're rotating that face so that it's rather horizontal right here. And then the picture in the upper right, we are going to go ahead and magnify our rendered view. And we're going to go ahead and cut away a little bit of the uterus so that we can see our little face a little better. So we put the scalpel coming right in front of the face and then out to the left, and then we rotate it a little bit more and try to make it a little more symmetrical. And then we take the image, and now our goal is to try to make this face symmetrical, and we usually use the orbits to help us decide. So in the upper right-hand corner, you can see the 2 orbits. So we're going to try to rotate that face, and so the orbits are flat as well. There we go, almost there. And I look in both the box in the upper right-hand corner and in the lower left-hand to see that the orbits are symmetrical. And now we're coming down and we can see the cleft right in the middle of the screen. Both up here, that's the tongue, and in the mandible, back up, and here's the cleft right here. And you can also see it on our rendered image. Now, if we tip the face up so that the profile has the forehead tipping backward, we will get, and put our cursor on the region of the lip, we'll get our classic 2D appearance of the cleft lip right in here. Of course, we can see that on our rendered image as well. So we can see this patient both pre and post repair, and I think this picture of the cleft is pretty representative of this little baby, and you can see the tongue sticking out between the cleft, and then you can see after the repair, which really looks quite nice. Now, that multi-slice, I think, is incredibly helpful to help us understand the pictures that we're taking, because this one, which is really at 1 millimeter slices going along the front of the face, you can see this is a pretty typical face right here of the frontal view that we would get on 2D of our lip, and the lip looks totally normal here. But as you keep going forward, then you will see that there is a cleft in the anterior part of the lip. And that's because this baby has an isolated cleft lip and a normal palate. And I think we are imaging just the anterior portion of the palate here, the gums, so to speak, making it look normal. So just like everything in 2D ultrasound, you have to scroll back and forth in order to reconfirm when you think that you have the right picture. Now, one of the new things that's come out in the last couple years is this concept by Dr. Sepulveda from Chile, and he has talked about the retronasal triangle. And that is this space right here on the front of the face, and that is part of the maxilla. And you can see that normal retronasal triangle, and then here you have a fetus with bilateral cleft, and this fetus had a bilateral cleft lip and palate. And he did this by either taking a 3D volume and putting a line through here, or a thick slice through there. And you can see this is a normal picture from our lab, which of course is not quite as beautiful as his from the for the paper. But the concept I really wanted you to get across is there's the profile of our little fetus. We put the cursor dot right in the anterior part of the maxilla as it's shooting straight back, and then we can see this retronasal triangle right here. We found in our lab that we could get it with 2D ultrasound as well as 3D ultrasound. And so we would take lots of our retronasal triangles with 2D because it was relatively faster for us to do it. But I think as I've moved forward, I've learned some benefits to 3D. So here's another patient in our lab that has a bilateral cleft lip and palate at 13 weeks. And here you can see that the clefts are relatively subtle. This one you can see the premaxillary mass, and then here's the clefts right here. But it was the premaxillary mass that tipped us off that something was wrong with the face. And you can see there's the little cursor of where we are in order to get this type of picture. Now, Dr. Sepulveda just last month presented a paper, a follow-up paper on his retronasal triangle, looking at clefts in the first trimester and showing that he could identify them, not just in the retronasal triangle, which would be out in this region, but that he also got the hard palate by doing the 3D volume and looking through it. Now, he does have the rendered views, which I think are, yes, they do show the cleft, but they're pretty hard to see. But I'm quite impressed with his pictures of the hard palate cleft there, this one's a bilateral, and here's another unilateral. And you can see these on this frontal view in a picture similar to the retronasal triangle. Dr. Platt came up with this concept of looking at the hard palate on a flipped face view. And what he did was he rendered with the face upside down, with the profile down here and across here, and got a picture of the alveolar ridge with the hard palate back here. And I must confess that I am on this paper as well. He showed it to me and I didn't believe it initially, but over a year, starting looking at it, trying it on lots of different patients, I became assured that he was right. And Dr. Fowl from France then wrote this incredible paper of 100 patients looking at the hard palate, which is really the same concept of Dr. Platt's. There's your alveolar ridge, and here's that hard palate right here. And I'm just still amazed at the types of pictures that he was able to get. With a little more experience, we changed in our lab to be more intuitive by putting the face upright and then having our rendering line slightly curved because of the curved nature of the palate, and looking at it upright because it was much more intuitive to us. And here's a typical picture with the palate right there, the alveolar ridge, the primary palate, and then the hard palate, the secondary palate back here. Now, the multi-slice does help when you have clefts because the nose is asymmetrical generally. So notice in this fetus, the orbits are perfectly symmetrical here, but as we go up, and these are 1 millimeter cuts, there's the nostrils, here we keep going, and then things just begin to not look quite right on the right. You still don't know exactly what's going on until we get to about here, and we should be in the palate. We have part of the alveolar ridge on one side, but not on the other. So there's a cleft palate coming through here, and it's going all the way out to the lip. So this is a cleft lip and palate, and then here's our mandible down here. And here's the rendered view of that fetus, and you can see that it kind of looks a little funny because the nose is asymmetrical, and this is exactly what the kid looked like after delivery. Now here's a picture showing our flipped face view that's now been changed to be upside down, and here's our rendering line, and you can see this cleft of the hard palate coming back here as well, and this is just a normal for comparison for you to see that alveolar ridge, and that not all of them are as beautiful as what you see in the books, and that's pretty classic. Okay, moving beyond the clefts, we also look at profiles. We can find a normal profile in patients that we don't have in a good position sometimes for 2D ultrasound, but by taking a volume, you can rotate the face and be able to get that normal profile. We can also assess babies that we think might have micronathia from 2D exams, or in looking for fetuses who have syndromes associated with micronathia. And we can also look at other masses like the proboscis, or in patients with holoprosencephaly, or encephaloceles or tumors. And these are just a few pictures, courtesy of Dr. Platt, of nice normal profiles. I just like them because you can just imagine, you know, your uncle looking like this, or this, or this, and they just all are a little bit different. So here's a patient that has Treacher-Collins syndrome, and you can see that as you look at this profile, that the chin is just way receded and small, and that's pretty classic for micronathia. And this fetus also had retrognathia, which means it's pulled posteriorly a little bit. But we weren't even looking at the ears, and we noticed something was going on here, and here's a normal ear for comparison. This is this little baby's ear when it was born. You can see it's really quite malformed. Now, when this case came through our fetal conference saying that one of my colleagues had called micronathia at 13 weeks, I was just blown away. But when I looked at the pictures, I go, well, yeah, for sure. Look, here's a normal profile at 12 weeks, which we do on all of our NT patients, and here's the nasal bone that they're looking for, and notice the mandible versus the maxilla, and in our case, you can see that there's a maxilla, but there's really no mandible. So this fetus did have micronathia at 13 weeks, and I just have another one at 13 and 5, and this is 12 and 3, just to show you what a normal should look like in comparison. We can also look for frontal bossing in patients with skeletal dysplasias to help narrow down whether they might have achondroplasia, like here, in comparison to this normal profile here. The nasal bone is quite important in association with trisomy 21. You can see that this is the frontal process of the maxilla. This is not the nasal bone back here. The nasal bones are the two dots that are anterior on this, and you can put the cursor on what you think is the nasal bone that we always take and see that that cursor is right there, and that's where the nasal bones are. These can be rendered, and you can see them on the 3D rendered view, but personally I usually use the 2D or multiplanar views to find it. Okay, next I'd like to attack the topic of the fetal head and brain, particularly looking at the cranial sutures for craniosynostosis or an abnormal appearance, to look for mild ventriculomegaly, and to identify the corpus callosum in all patients with mild ventriculomegaly, to talk about the vermis size in patients with suspected Dandy-Walker variants, and to talk about cystic lesions in the brain, such as the cavum vergae, the third ventricle, the vena Galen aneurysms, and interhemispheric cysts. So this is just a video clip showing cranial fontanelles in this little fetus, where you can see the big main fontanelle superiorly that we use all the time to do ultrasound on in neonates. That's the frontal fontanelle. And then here is a rendering of the normal skull showing the coronal suture and the squamosal suture. And then here's a fetus that has craniosynostosis, and you have no coronal suture there seen. Now, we pick these up often by our 2D exam, and we realize that the head shape is not normal. So here you have a normal, nice oval head shape, and you can even see part of the coronal suture right there, part of the lambdoidal suture right here. And then here you have a fetus that has craniosynostosis, and you can see that it's kind of indented at the region of the coronal sutures. Now, I just want to remind you which sutures they are. The coronal is this one that's between the parietal bone and the frontal bone and the parietal bone. This is the squamosal suture, the lambdoidal suture, the mastoid, and then the zygomas right here. When you look on FOSS, you can see the sagittal suture and the anterior fontanelle, the coronal suture, and the metopic suture. So here we have our fetus with craniosynostosis, and what's important to notice is that we need to take a narrow volume right along the anterior portion so that we just get one side of the head in our rendered pictures to look at whether that is intact or not. And if we that one has craniosynostosis, whereas this one we narrowed along the front, and you can see that nice normal suture. And then here we can narrow it along the bottom of the head, and we can get the other coronal suture. And that's that squamosal suture there, and that's part of the lambdoidal suture in the back. If you want to look at the sagittal suture, you need to render it along the superior aspect on a profile view, and then you can get this beautiful fontanelle, anterior fontanelle right here, seeing what size it is. Now, Chowie and Bernard Benoit published this paper looking at metopic sutures and showing what a normal metopic suture looks like at 19, 23, and 30 weeks. And then an abnormal one that they called V-shaped, and then a Y-shaped one, and then a U-shaped one. And then here we have premature closure like we did in the case I just showed you. And then here's some additional Wormian bones in both of these cases. So how do you get that? You come along the anterior or frontal part of the face, and you do a thin rendering right along that region in order to get this type of picture. Because one of the problems with 3D is we'll show you beautiful pictures, but then how do you get them? So looking at the multiplanar view is critical in being able to identify how you get the pictures we're showing. Now, just to show you that it's not so simple, this was a family that came in with a history of familial cranial ossification defect, and mom had it herself. And this fetus I studied at 18 weeks, and you can see that it looks pretty far apart. And in comparison to those normals that I just showed you, let me just go back one here and show you. Look at this at 19 weeks. You know, it's pretty closed by then. And so I had comparisons, and I was quite concerned, and I told the family I was concerned that the fetus might have the same ossification defect. But when she came back 3 weeks later at 21 weeks, she looked normal to us. So I think we still have a little ways to go in understanding the normal variations of what we should be able to see in our normal population as well as our abnormals. Next, I'd like to just show you a fetus that might have mild ventriculomegaly, that we always go and try to find the corpus callosum on top to see if we can identify it, because often mild ventriculomegaly will be associated with absence of the corpus callosum, particularly when those ventricles look parallel or teardrop shaped. Here is a patient that has a cyst in the middle of the brain, and it's we put the cursor right in the middle of that, and we see from the sagittal view that this would be the cavum septum pellucidum and this would be the cavum vergae. And it helps us identify that this is just a normal structure. I want to remind you what that looks like. Here's the cavum septum pellucidum, and here's the cavum vergae posterior to it, and sometimes it disappears first and collapses. But in our fetuses, we often see it. And you can also have a cavum velum interpositum behind that. In patients that have agenesis of the corpus callosum, you see that cyst here, and you don't see any, and you can see that cyst is kind of elevated, and this can be the third ventricle that's elevated because there's no corpus callosum. And I think when we turned on color here, the color wasn't particularly helpful in this case, but sometimes it's very helpful because you can't find the paracallosal artery. Now, probably the most common place I'm using 3D in the brain right now is to look at patients that have suspected Dandy-Walker variants. We see this kind of cystic area in the posterior fossa, and it's connecting up into the region of the fourth ventricle. And yet the cisterna magna, we can see a normal part of cisterna magna, and we just don't know whether it has a Dandy-Walker variant or not. We know that this is normal up until 18 weeks based on work that Dr. Benasraf has done, but so we'll bring them back, but then we measure the vermis. And how do we do that? We line the head up so that it's symmetrical, so that we have the face on in a profile view and the spine coming down so it's all intuitive. And then we know where the vermis is because we can look at it in our other planes and decide where the upper portion is and the lower portion. And then we can measure this and we can plot it on tables to see whether it's within normal limits or not. So here's a patient that does have a Dandy-Walker variant with the cystic structure from the cisterna magna going up into the fourth ventricle. And then when we do our sagittal with the spine coming down, we can measure that vermis and see that it is small. So cardiac 3D is done predominantly using STIC, or spatial temporal image correlation. This is a technique where there's a series of volumes that are acquired and saved, and then they're reviewed in their multiplanar images of the heart throughout the cardiac cycle, and it appears that the heart is beating in this multiplanar display. So here we have a four chamber that we're rotating on. We're putting the cursor right on the septum, and you can see as we move the cursor up above the left ventricle, we get a picture of the right outflow tract in the upper right corner. And that's because the left outflow and the right outflow tracts are perpendicular to each other. I want to show you that clip one more time. We rotate on in the y-axis, and we see the left outflow tract here. We move our cursor up, and on the opposite plane, you see that right outflow tract right there. And I just want to move that back just a little bit so you can, where the clip stops, and you can see that bifurcation of the right outflow tract with the aorta in the middle. And I think that's incredibly helpful to teach people how to get these on 2D. Now here's the ductal arch that we find by finding the descending aorta, lining it up, and then we rotate on it, directly into the aortic arch, and there are the vessels coming off the arch. So this is, if you can't get your outflow tracts in your traditional ways, we will always go and put it along the descending aorta, along the spine, put the cursor in the middle of the aorta at about the level of the diaphragm, and then just rotate on it, and you will go from your ductal arch to your aortic arch, or vice versa. I find this very helpful on 2D. I just go looking for the descending aorta and start rotating on the spine and trying to get my arches. Now this is a patient with a muscular VSD right here, and we can see that both in the 4-chamber view here, and we can also see it on FOSS right here, and on this view. This is using the new matrix array transducer, and we can see the VSD right there, and then we can see it in another plane over here as well. Here it is right here. There it goes. Okay, here is a picture of the ribs and spine. Just to remind us that 3D can count the ribs as well as start looking at the spinal elements. And in this paper by Dr. Gendis and Dr. Benoit again, you can see these beautiful pictures of the ribs, and there's 12 here. Here's one that's an absent rib. You have it on one side but not the other. And here's one that had 13 ribs. And ribs can be helpful in correlating with Down syndrome, as they can have abnormal number of ribs. Now this is a patient that has a Chiari-2 malformation, and I just put this here to show you that the rendering can sometimes be misleading. So this was the spine coming down, and then you can see this widening out here. And I thought it was really beautiful, and 3D was showing the spinal abnormality nicely. And then when I heard the fellow dictating this case, I realized she was dictating it as if it started here. And to me, the defect started right up here. So the rendered pictures until you've seen quite a few rendered pictures, I really don't think that you should make your diagnosis predominantly from the rendered. It should be an adjunct to your 2D ultrasound, because on 2D, you can figure out the levels as well. You may not be perfect of which number it is, but you can see the widening. And here you can see on this patient the widening of the spine on the x-ray from after delivery. I do think that 3D you can manipulate your volume nicely to be able to figure out, based on the 12th rib, where you are. And this is someone who is at an L2 defect. Up here it looks almost normal, and then by the time you get down to L5, you can see this large mass here with increased echogenicity. And this was not just a typical meningomyelocele, but rather a myelocystocele, which was associated with a tethered cord and a lipoma in the back. This fetus had normal head findings because it wasn't a typical Chiari. Now this is a patient that had scoliosis, and she came as a referral, second opinion, for scoliosis, and you can see that 2D shows the scoliosis, and the family had already been told that. But when we did the 3D rendering, they could really tell the angulation of that spine, and it was no longer a scoliosis that was just a little bit of a curvature of the spine, but the family all of a sudden realized how much of a deformity this was going to be. And this fetus didn't have just regular scoliosis, but rather spondylocostal dysostosis as a final diagnosis. So I think the 3D pictures, when I walked in the room, they were already quite aware. They could see it on the monitor themselves. This is a picture of liver calcification, and sometimes we'll use 3D just to take a volume to say exactly where it is, because in one plane you may not be quite sure, but when you put the 3 planes together, you can figure out that this really is in the liver, and it's in the right place to be in the liver. So I think 3D is a great troubleshooting tool. We do use it for club feet, like in this patient, where you can see it of both the right leg and of the left leg. And here you can see it. It's I don't have the video to show you it rotate around, but I think it can be quite helpful to confirm a club foot. This is a club hand in a 13-weeker, and you can see it on the 2D quite nicely, that's what it is, but I think for the family, it's much more apparent on the 3D image. This fetus ended up having trisomy 18, which is common with fetuses that have abnormal hands and feet in the first trimester. Now, artifacts occur in the 3D ultrasound just like they do in 2D ultrasound, and you can see that it's important to identify that this is just an artifact of the rendering. It's not a hole in the head. And when we first started doing 3D, a lot of patients would say, why is there a hole in the head? But it's just that the rendering box is going through the cranium. And you can see this looks like a conjoined twin or something with two faces, but it's just that the single fetus moved, and that you can get part of both faces when it moved. 3D can be helpful in looking at the fetal face, particularly in displaying a normal face or normal anatomy when the patient is at risk for some particular anomaly. Perhaps there was a prior child with an anomaly or someone in the family. It can also be helpful in displaying normal anatomy in fetuses that have anomalies, such as like a omphalocele, looking at the face and knowing that other things look normal. It also helps with more comprehensive understanding of many anomalies like cleft lip and palate, like anencephaly, like clenched hands with trisomy 18, straight arms of movement disorders. And I remember this fetus that the mother just didn't get it, but when you showed her this picture of this really straight arm, all of a sudden they realized that this wasn't really normal. I already mentioned the omphalocele, and also some of the really short dwarfisms or skeletal dysplasias are very apparent on the 3D image. I would comment that some families will have a bias in how they look at the pictures, and I know I had one patient that had a very flat midline cleft in the face, and the family thought the 3D pictures looked quite normal, and when they saw the baby at delivery, they were just horrified because it didn't look anything like what they thought the 3D picture looked like. Also, I've had cleft lips be both directions. Some think it looks worse, some think it looks better than they anticipated. That's just our little fetus with the omphalocele, and the family really adored having the picture of the face because all of a sudden they could think about it that way. When looking at clefts, I think this cleft, this family at 28 weeks, which I think it's a study from a long time ago, but the family said this cleft is just not nearly as bad as I thought it was, and they decided to not terminate when they had planned to terminate for it. And this mother, who had seen this picture that I showed you earlier, said she was absolutely horrified at delivery because she just didn't believe that there was a cleft lip on the baby, even though I showed her these incredible pictures. So in our first original series that we published in 2000, 4 of 28 fetuses with cleft lip and palate changed their mind regarding continuation of pregnancy after having a 3D ultrasound. If there is an anomaly, I think it's very helpful to give the family a picture of the face, because all of a sudden, many families have told me they stopped thinking about the club feet or the omphalocele when they realized there was a baby in there, and the face helped them kind of come to that. I think in our everyday practice, we show pictures of the face to parents all the time. It's what they want to see, and I think our pictures are getting better and better, and some days you'll get really great pictures and other days you won't, and all depends upon the fetal lie. Now, I'd just like to finish talking just a tiny bit about early pregnancies, and particularly ectopic pregnancies, where I think 3D ultrasound can be incredibly helpful. It can help differentiate an ectopic from a uterine malformation, such as a septate uterus, and figuring out that it's really not an ectopic or an interstitial ectopic, but just a septate uterus. And the thing to realize is that interstitial ectopics will occur right at the edge of the uterus as the fallopian tube is going out, and corneal ectopics have a can look very similar. They really occur when you have one horn and then you have just a residual amount of horn on the other side, like in a unicornuate pregnancy, and the ectopic occurs in that little cornea of the one that's not there. And then, of course, there are cervical ectopics. It's important to locate the ectopic or the gestational sac in 3 planes to be able to assess how close it is to the myometrium and how much myometrium there is. So, for example, this is an interstitial ectopic pregnancy, and you can see here's the endometrium of this uterus. The uterus itself is here, and we can see this gestational sac off to the right with a little line right here called the interstitial line going from the endometrium to the ectopic. Now that's in contrast to this patient that was sent to us to rule out an interstitial ectopic. And you can see that this gestational sac is way up here. The rest of the endometrium looks fine, but it's a very broad base to this ectopic, to this gestational sac. And there's a little more myometrium around it on the transverse plane here than you would expect for an interstitial ectopic. So we brought her back just to see what happened, and 4 days later you can see that her gestational sac is exactly where it ought to be, a normal appearance in that endometrium, and she had a normal intrauterine pregnancy. Now this was a patient that came to us at 7 weeks, 6 days as a possible cervical ectopic or a C-section scar ectopic pregnancy, and that's what she turned out to be. And how it unfolded was you could see the sac, and there was the endometrium on the 2D ultrasound, and you didn't know exactly where it was. We did see some blood or gestational trophoblastic disease up in the normal position of the endometrium. And as we scan her on 2D going back and forth, we even found a heartbeat on this little one that was about, I think he said 7 weeks and 6 days. But then when we did 3D, I think it was just really helpful to line up the cervix here and see that it was in the position perfect for a cesarean scar ectopic. There's the bladder right here, and it's sitting right there in the middle. And we did end up going on to do an MRI because they're not common. This was our first one for us to identify, but now they're becoming more and more common. And here you can see the endometrium, and there's the ectopic. So I think, in your first case or two, you may feel like MR would help to confirm exactly where this ectopic is. You want to differentiate it from a cervical ectopic, or the other main thing is just an abortion in progress. So what is it that you have learned today? I think you should remember the applications of 3D for the fetal brain. I want you to remember agenesis of the corpus callosum, Dandy-Walker variant, and measuring that vermis. And I want you to think about, is it just the cavum vergae? Put your cursor right on the middle of the cystic thing if you see a cyst in the brain, and see if it's the normal cavum, or whether it's the elevated third ventricle, or whether it could even be a subarachnoid cyst. Where do cleft lips occur? Look at that second lateral tooth bud. At that lateral incisor, that's where you're going to identify your clefts. So whether you're looking at 2D or 3D, that's the position to look. How do you render the cranium to see the sutures? You need to acquire the volume with a specific suture in mind, so that you won't get shadowing, so that you can get a picture coming directly down on that suture, whether it's the coronal suture or whether it's the sagittal suture. And you must do only one side if you're looking at the coronal suture, one side at a time. Thank you very much, and I wish you luck in using 3D ultrasound in your laboratory.